and verse on how variants are likely to unfold or not. We'll give you some scenarios, but we have to be able to plan for all of those, even if we think some are less likely, because they may be less likely, but it's still possible.
So does the public health advice in relation to pre-departure testing say that you should keep it until the variant plan has been unveiled, or is it a bit more?
I'd have to go back and look at the exact nature of the wording, but I mean, it is fair to say that the public health advice is that the value of pre-departure testing is not what it was.
Okay.
David is next in the queue, but can I just check were there some sups from members on that?
Yeah.
Dr. Sharma?
Well, thank you, Mr. Hipkins. I guess I just wanted to echo what Press Bishop was saying as well. I was recently in India for an official trip, and I just found that coming back home, having a 48-hour pre-departure test was kind of very difficult logistically to get done. But also I've had a constituent who, for example, did these 55 hours and they were coming back from Africa and then ended up getting a $1,000 fine. And their concern was they just couldn't meet that 48-hour deadline. And there seemed to be very less flexibility, obviously for genuine reasons that, that fine was removed. But similar concerns around, is it still needed? And I appreciate that you're looking into it.
Yeah, I mean, I've been sort of following international developments on this pretty closely. It'd be fair to say that the world's response is hugely variable. So some countries, the requirements they have are still quite onerous, very onerous compared to New Zealand's, while others have signalled that they'll be making changes. Not all of the changes that have been publicly signalled have actually come into effect yet. So, for example, you still need a pre-departure test to go to the United States at the moment, although they have signalled, I think, that that's going to be removed. It hasn't yet been removed.
Thank you. David Seymour, then Debbie Ngariwapeka.
Yeah, hi, Chris. I'd just like to ask, what at this point, what are the goals of COVID policy in New Zealand? Are we trying to minimise cases? Are we trying to minimise hospitalizations? Are we trying to minimise deaths? Are we preparing for a new variant that might come? What are we trying to achieve? And how can we be sure the policies and interventions in place have benefits that outweigh the costs? Because the costs are considerable. I mean, you look at pre-departure testing. I was just talking to someone yesterday. They got turned away from a flight because their pre-departure test was 48 hours and 15 minutes old. This kind of stuff is happening to people all the time. I was talking to a psychology practice operator, a psychologist in Mount Eden yesterday. He said that the 7-day isolation period is decimating his practice, not to mention massive amounts of demand because of the anxiety caused by the last 2 years. So can you tell us what the goals are, how we measure them, and how you reassure us that keeping these interventions in place is actually making sense?
So if I start with the first part of your question, which is about, what are we trying to achieve? And it is a combination of the things that you have mentioned. So it is about reducing hospitalisation and ultimately mortality from COVID-19. But also about preparing and being prepared for what COVID-19 might throw at us in the future. And that is always, as it always has been through the pandemic, one of the most challenging things, because you don't quite know what's around the corner. So being prepared for all of those different scenarios. If I take some of the specific concerns that you've raised in there, we look really closely, and we have been regularly reviewing the evidence around the isolation periods, both for cases, because at the moment 7 days for cases and 7 days for household contacts. And the numbers on that, we're due to get some more numbers on that in the next few days, sometime in the next week or two, around what changing or altering those might do for the overall number of cases. For example, the previous modelling suggested that even removing or even lowering the isolation period for a case from 7 days to 5 days could result in a significant increase, up to, I think it was from memory, about a third in the number of onward infections from that person. And there's a flow-on effect then to hospitalisation that goes with that as well. But some of those numbers, I think, may well be shifting. It's all based on, statistical modelling ultimately. And so as the pandemic evolves and as we get more cases and more numbers, the numbers can move around. So we're expecting more. At the moment, so the most recent evidence we had suggested that change could be significant, but that might not always be the case. And it may well be that we reach a point where further changes can be made without without the, as big a flow-on effect. Ultimately, though, we have to sort of weigh that up because, and it is a challenge. People isolate for 7 days and then they get a positive test result on their 7th day. And I understand that. I mean, I was in that situation. I was at home for 3 weeks, basically, by the time I worked through our family. And that can be really challenging. And I acknowledge that that's challenging for families.
Okay, so for example, if I was to ask, how many cases, hospitalizations and deaths are we saving through our pre-departure testing regime? I mean, do you know that number and reasonably recent update?
Well, in terms of pre-departure testing, if you're looking at that specifically, as I've indicated, I think the evidence base is suggesting that the utility of pre-departure testing is a lot less than what it was, and we're in the process of making decisions around that. I don't have updated numbers, but it won't be making a significant contribution to the rate of hospitalisation that we have at the moment.
But what I'm hearing is that we're putting these significant impositions on people, and at some point in the past it may have been worth it. You're not sure now, but we'll review it in the future. I mean, I just feel that people who are having these costs imposed on them deserve a much sharper analysis of whether these policies really are achieving a public policy benefit, or because they feel insulted having their time taken up and having their businesses under pressure, having to spend 2 weeks at home because of consecutive cases in their family. Can't we do better on cost benefit analysis here?
Yeah, look, and I think it's not an unreasonable point. And as I've indicated, the pre-departure testing is something that we are in the process of making further decisions on at the moment, and it is linked to the variant strategy. I think it'd be fair to say that in terms of if you were, deciding where the best place to do testing is on arrival testing, not pre-departure testing, because actually on arrival testing gives you information you can follow up on. That's not a perfect science either, because if you're using on arrival rapid antigen tests, what we found is that a significant number followed up with PCR testing either don't get a positive or you don't get a sufficient viral load from the positive to be able to do a whole genome sequence. But we're getting enough to actually give us a really good indication of what's coming across the board.
I know the chair's going to run out of patience with me, so can I just do some rapid fire? I mean, it seems to me nothing's perfect, but we still expect perfect compliance from people and following these rules. And that, I think, is the frustration. Just thinking about boosters, there's two groups of people concerned about this. One is medical professionals saying, when do we get our second booster? We're going into hospital. Our chance of exposure is very high. There's still Delta cases. When will that be available? But equally, there are other people who are saying, look, I had a bad reaction to my second or to my last booster. To my second shot, I'm now mandated out. I heard from a nurse just last week, actually a midwife, someone we're very short of in this country. She's had COVID, which means she's got an extra 3 months before she needs to be mandated to have a booster. She won't have one. I was at Dilworth School visiting the principal. They're missing their chaplain because he had a bad reaction. His doctor accepts it's a known response. He's had 2 doses. He's not, crazy about this stuff. He quite reasonably says, I don't want to risk the third. Dilworth needs its chaplain right now, as I'm sure you know. So, are we going to keep mandating boosters while other countries stop doing it? Australia doesn't do it. Why are we?
I think.
And when can we get them if we do want them? We're all pro-choice here.
Just acknowledging the issue that you've raised about people who've had an adverse response to a vaccination. I have asked for more advice around that because I think that that's a legitimate point. The issue around
what specific point? Just around adverse reactions.
Yeah. So no, if someone's had a serious adverse reaction to a vaccination, whether there should be, for those who are subject to a mandated requirement, whether there should be greater flexibility there. Okay. The issue around 4th doses, second boosters, however you want to term it, is one that is our technical experts indicating to us that it would be desirable to have a 4th dose. No earlier than 6 months after the most recent dose, which means for us that's kind of coming up in that June period. So we're not there yet because of when we administered the first round of boosters. And so we're preparing to make provision for that, so that within the next couple of months people will be able to get that extra dose. There is a regulatory challenge that we have because our Medicines Act is such an antiquated piece of legislation, which the Parliament will eventually turn its mind to. There is work in progress to replace the Medicines Act with the new therapeutics legislation, but at the moment we're stuck with the legislation that we've got, which means that if Pfizer don't apply for a regulatory approval for a fourth dose, it's very difficult. Well, MedSafe can't approve a fourth dose, and so we have to find a way of working our way through that, which we will.
Yeah, skip those guys.
No, we're
Sorry,
going
look,
to.
I'm running out of patience here. But
Yeah, we've got there. We'll come back to you if there's time. Debbie Ngariwa-Paka.
Tēnā koe. Thank you, Chair, and thank you, Minister, for this morning. Or is it, yeah, it's still this morning. A few questions, and I guess I'll start with the first one, which has been quite pressing for a lot of us, is why did it take till February of this year to stand up an equity group? The Māori unit in the COVID response is 18 months too late.
I don't agree with the assertion in your question. Equity has been a consideration right the way through our COVID-19 response. And in fact, I would argue that the first 18 months to 2 years of our COVID-19 response have been some of the most pro-equity responses a New Zealand government has ever taken to any issue. And I think that the overall outcomes that we've achieved from our COVID response clearly demonstrate that.
I think, we'll agree to disagree. I saw another end of it, being on the ground. I saw the way that the vaccination rollout completely missed the equity space, and I was part of the movement of Māori providers who stood up their own response. Assuming and entertain me that my assumptions are correct, what have we learnt, or what have you learnt, or the public health response learnt from Māori efforts during this, and what would be done differently?
I think what we have since the beginning of the vaccination rollout, for example, put a lot of funding directly into Māori health providers in order to make sure that we're reaching into those communities. I think the feedback that I've had from them, and Minister Hinari and I have had a reasonably frequent engagement with the leadership of our Māori health providers. I think that there are some things that we should take away from all of that. I think that there were some issues around data that no doubt we can definitely take away and look at. I think they rub up against some tricky areas for us, though, in terms of where different constraints on government interact with one another, and privacy being one of those. The other lesson, really, and it's one that we're all struggling with, is the topic of misinformation, and that there have been some communities in New Zealand that have been more prone to misinformation. And some of our Māori communities have certainly, and I know that you'll be aware of that, having been involved in the vaccination campaign, have been subject to a more concerted misinformation campaign than others.
I think, and again, if I just come back to this equity group that was stood up, do you think in hindsight that there should have been something specialised like that? And again, I know this is the recommendations from Te Ropu Waka Kaupapa Urata, that should have been there in place in the first instance, that would have actually been able to address all of those matters that you've said, that were actually quite ad hoc, and they were often conversations that happened at the bottom of the cliff, things had already gone wrong.
Well, look, our government's criticised for setting up lots of working groups and committees, and you can have as many working groups and committees as you like, ultimately. But actually, it's the outcome that you've got to look for. And if we think about the equitable outcomes that we've achieved through our COVID response, they've been some of the most equitable in the world.
Another thing I'd want to get into is, why is COVID not folded into the present health reforms and running extra costs?
I'm not sure what your question is there.
Can I just ask a quick stuff on the previous one?
I think if, Debbie, if maybe you can just have a little think about that, because David's got a sup on one of your early
very
ones.
quick stuff on that question.
Sure.
What has been learned from the Māori response, but equally, what has been learned from the extraordinarily high vaccination rates of Asian New Zealanders, many of whom face language and cultural barriers, but nonetheless managed to get the highest vaccination rates of any ethnic group in the country? I wonder if there's anything to learn there.
I think it's certainly worth looking at. Absolutely. I think some further attitudinal research in that space would be very, very useful. we're being criticised at the moment for spending money on attitudinal research, but I think in that space it would be very useful.
Quite rightly, but I think we should also look at the successful parts as well.
Yeah, if I can come back to, so thank you, Chair. If I can come back to, I guess we know that we've got Māori Health Authority. We know that there's been a lot learned, and then there's the present health reforms, and there just seems to be a mismatch between some of the things that are happening with COVID ongoing and how that's aligning with the health reforms, particularly again from a Māori equity perspective. And I may have this completely wrong and would seek your clarity on that then.
Yeah, I'm still not entirely sure what it is that you're asking, but I can give you some reassurance that, I think that the health reforms and the work around the health reforms is absolutely drawing on the lessons from our COVID-19 experience. Okay, so
I'll give one example with data. So we know that data, as you said, was an issue in the COVID response. And let's just say this time next year, we need to gear up again for something else that's come through, a completely different pandemic. What and how does that then get absorbed into the changes and the reforms that are happening within the public health response? How do we make sure that actually we're not running a parallel action and that, in fact, what has been learnt has been evolved to the Māori Health Authority?
Yeah, I think...
Or devolved, evolved or devolved.
Some of these answers sit with the system, but some of them still sit with us as politicians. So if we think about data, the Ministry of Health is still constrained by the Privacy Act. And so if we wanted them to do things differently, then to some extent, we actually have to look at what the regulatory and legal constraints that bound their hands in that were. We also have to think about the fact that there are some political decisions to be made around the use of data. So if we think about tamariki vaccination rates, for example, we know that we have quite a high degree of hesitancy amongst some of our parent communities, and that the sharing of data around whether or not they've had their children vaccinated will be a point of significant contention for those whānau. And so I think we have to tread carefully there as well.
I think I'll invite Dr. Bloomfield. I think you want to respond.
Thank you, Chair Morena Koto, and thanks, Minister. I just wanted to give one very specific example of how we've translated that learning, and it relates to the data. In fact, we've already proactively made the data available on Māori who are eligible for vaccination, and indeed Pacific, to the relevant providers. And that includes all organisations, so that will include whānau Waiperera in Auckland to support the influenza campaign. So we haven't waited, we've done that proactively based on where we have ended up with the provision of data around our COVID-19 vaccination program.
Kia ora. I just have one follow-up question, thank you, and all the best wishes to you as well. Will the government direct all schools to support the provision of paediatric vaccinations off school campuses? Is that somewhere that you see that you're going?
What I would, this is actually a really complex issue. It's one that I've spent a lot of time wrestling with because I do see benefits in having vaccination on school sites. Having said that, we know that we have also seen an increase in the absence rate of children. And there are a range of concerns that are underpin that. You've got some people at one end who are concerned that they don't want to send their kids to school because they don't want them to get COVID-19. But at the other end of that spectrum, you've got some parents who are not, and school principals report, this is anecdotal rather than any statistical evidence that I've got for this, where they're saying that parents are not sending their kids to school because they think that they're going to be vaccinated against their wishes if they send them to school. So we have to tread carefully in that area as well. I want those kids in school, and that's the primary job of the schools, is to actually is education. The idea that we'd have a mass rollout of vaccination within schools that would vaccinate children without their parents' consent is one that I'm not willing to entertain.
Absolutely.
And ultimately, it's parents being willing to have their tamariki vaccinated that is the biggest impediment to getting higher rates of childhood vaccination.
Thank you, Debbie. We'll go to Sarah Pallett, then to Shane.
Thanks, Mr. Chair. Morning, Minister. Morena, Dr. Bloomfield, and just add my thanks to you for all your hard work and everything you've done, and wish you all the very best. My question's around MIQ. As MIQ is being scaled down, just really curious to know how that's going from an operational perspective, and also looking into the future, what plans are we making, what longer term plans are we making for any potential use of MIQ and how it might operate differently?
On the latter part of the question, it's still kind of early days around thinking about what a future pandemic might require. It might require some kind of isolation or quarantine capacity that might be different in nature to what we've had for this pandemic. In reality, if we had to do something again quickly, and again, I've indicated that I think that this is one of the less likely scenarios that we might face, but if we had to, the system that we had could be stood up again in the event that we needed to do that. It's in the process of being wound down now. I want to, I will use your question as an opportunity to thank the workforce there. They did us very solid work over the 2-year period that we're doing, just over 2-year period that MIQ was in operation, and many of them are now out finding other employment. And that's pretty tough because they took one for the team. And so I think we all owe them a vote of thanks for that. And the MIQ team, if you've got anything more specific, are here and can answer that. But the wind down process is going well. We're down to, I think, only 4 facilities left in operation. It's a very small number of people. It tends to be refugees, people coming from Ukraine, Afghanistan, etc. And I think we might have still had a bit of work around the Antarctica program where people are isolating in New Zealand before heading down to the ice. But it's a very small operation now compared to what it was, and it's being wound back. And by, I think it's by August, we'll be down to nothing.
Wow. Okay. Thank you.
Dr. Shane Reddy, then Chris Bishop.
Thank you. Kia ora koutou. Thank you, Minister Ashley, and your team. I'm interested in the COVID response performance framework at a system level. That if we look back in 2020, around about March, started with what I'll call the behavioral metrics. They were iterated and finalised about May 2020. What happened from then to now? What were the iterations, and what is the performance framework at a system level today?
Yeah, so the contact tracing metrics are very different now to what they were back then, because obviously we're dealing with a very different scenario. So it's more about there's a much more automated nature to it. So if someone's had COVID-19 and they report their rapid antigen test result through My COVID Record, there are different kind of triggers for what kind of response they'll get. But if I take myself, relatively healthy, not someone who's going to raise a lot of red flags, I got a phone call from my GP because that's where the system directed my positive test result. It worked superbly well, versus someone who maybe there's more concern about, they might get a slightly different response. So they may get a higher level of intervention than that. And that system is working quite smoothly, but it's a very different system to the one where we were, case interviewing every case to identify who their contacts were. That's not happening now, except at the margin. We still have some ability, for example, with a new variant, if there's a new variant of concern, we can liven up some of that in the event that we needed to do that. The team here will be able to tell you what they've done, for example, around what are we up to, BA5 now, with the limited number of cases we've had, there's been more activity around those cases. In terms of what happened in between time, so that's where we started, that's where we are now. A whole spectrum of stuff happened in between. It'd be fair to say that those metrics, and Dr. Verrill herself would say this, didn't necessarily adequately account for the fact that at different stages in an outbreak, the metrics are probably going to be a bit different, in the sense that, so take the Delta outbreak, or the Delta outbreak will do. We didn't detect that until it was already well seeded. And so hence most of those metrics for the first couple of weeks, we were never going to hit them. So in that early part of an outbreak, your focus really is on, are you doing enough to catch up ahead of it and get a ring around it? And then once you've done that, then some of those metrics are more useful. And so I think if we were going to start the process again, I think you'd need a system that's more nuanced, recognising that different metrics are going to kick in at different, and we have that now. So if you look at our Omicron response, for example, we dealt with it in can't remember what we call them. I think we call them stages. Stage 1, stage 2, stage 3. And we had different metrics for each of the stages.
And each of those stages have targets that are monitored and reported?
Yeah.
Okay, thank you. Testing stations during the Christmas period, say from 1 December through to middle of January, asked some questions around that. And it just struck me that if we looked in the main centres where the 24/7 main testing stations were, it seemed to me most of their testing hours were from like 8 to 4, for example, like Toll Stadium in Whangarei. It didn't well suit, for example, a business environment, and we're wanting to encourage people to do the right thing and make it easy for them to do the right thing. Do you have any reflection back on the availability of testing stations and how well we did then? Yeah,
look, I'd look at it both in terms of testing and vaccination, because I think certainly in the early part of our vaccination effort, that was also a challenge. I was asking on an almost daily basis for, I want a list of every after hours vaccination clinic that's operating in the next, 48 hours, because I think that was a constraint. And I think we needed to have more of a, not 24/7, but certainly more of that after hours and in weekend activity. One of the interesting things that we're seeing now is that you'll see testing rates drop off dramatically in the weekends, and they spike on a Tuesday. And of course, the reason they spike on a Tuesday is that people do their tests on a Monday, and those tests get reported on a Tuesday. So that's just human nature, I guess.
But it sort of leads into, do you have any sense how many positive rates are not being reported?
I haven't got any empirical data.
It's impossible to know.
It's impossible to know, but it would be fair to say I think scientists can probably give you a bit more of an estimation. There's no question there's a lot more COVID out there than the statistics will be showing.
Well, then put that another way, the number of people who call or report in their RAT positive test and then don't hang up, they don't get to completion through the reporting process, that's probably a starting point for those who may. Do you have any numbers around that? Because the process takes too long and they get cut off, whatever.
Yeah.
But the number of people who call in a positive test and then don't proceed any further, they hang up before they can get to an operator. Do you have any?
I think most people are reporting them through the website, but
through the app,
yeah,
actually. So most of it now is automated rather than phoning the helpline.
Yeah. Again, there are different stages here, though, because for children, I think the website went live about 3 days after my son tested positive, the website that allowed for an adult to report a child's result, for example. And so we know that there was a period in there where we would have lost a whole lot of childhood tests because parents didn't go back and report them after that went live. So,
okay. My last question, the reporting criteria changed to say a person succumbed with COVID if they tested positive in the 28 days. Is that being retrofitted to when COVID first hit our shores? Is that definition being passed backwards to look at how many people might have died with COVID under this new definition?
I might get either Dr. Bloomfield or Dr. Town to make a comment on that. Dr. Bloomfield, I think, he's been boring into this quite detail in the last few days. So,
thanks, Minister. And the short answer is yes. Every death of someone who had tested positive for COVID, and of course, until the recent Omicron outbreak, that was a much smaller number of people. So we certainly knew the testing result for anyone who died, whether or not it was within 28 days or after 28 days. And we're just about ready to publish the sort of retrospective breakdown of the deaths that have been reported to date, to divide them into those three groups: the ones where we can confirm COVID was the cause of death, a second group where COVID contributed to the death but wasn't the primary cause, and then a third group, and there are some that are very well-known examples, where COVID was incidental to the cause of death. That's a much smaller group. And then there are still some that are outstanding because with the coroner or more information is being sought, but we'll have that information and that breakdown right back through to the start of the pandemic available in the next few days.
How big is that uncertain group?
At the moment, it's about perhaps 10 to 15% of the total deaths. So actually, we've got a good indication from the vast majority of the deaths to date about whether COVID was the cause of death or not.
Thank you.
But just coming to your point, I think and Dr. Bloomfield will correct me if my memory is incorrect, but the first two categories account for more than 80% of the deaths. So it was either a contributing factor or the factor in somebody's passing. So I'm just aware that there are people out there who are saying, well, the stats are all wrong and deaths are being overreported because people just incidentally had it. That is the minority. Yeah.
Thank you.
Thank you. So we go Chris, Elizabeth, then David. So Chris Bishop.
Yeah, just a range of different things. Unvaccinated permanent residents
Yes.
being allowed into New Zealand. The decision was announced on 2nd of May. When did you get advice on that?
I asked for advice because I mean, ultimately, just to run back, as you'll be aware, that the reason for allowing citizens to return was there's a legal imperative for that. We can't stop a New Zealand citizen coming in, regardless of what we might want to.
Qantas tried to stop me the other day.
The permanent resident decision, it became pretty apparent as we were opening up more widely that New Zealand governments, plural, over time generally haven't made much of a distinction between a citizen and a permanent resident. And so I wanted to get, basically I asked for that advice because I wanted to get back to that position where we were treating, citizens and permanent residents on the same basis.
Okay, so what I'm just trying to understand is the timeline, because there was quite a gap between the citizens' decision and the permanent residents' decision. So did you actually have to proactively ask the ministry for that rather than the other way around?
I know I specifically asked for it, but I can't remember whether it was in the works when I asked for it or not. But I think there's been a lot happening in that space, as you will appreciate, over the last sort of 4 or 5 months. So
yeah, okay, okay, all right. The issue of PCR testing in the first quarter of this year, with I think it'd be fair to say, the overwhelming of the testing system, particularly in January and February, 10,000 or so tests sent to Australia for testing, and obviously people waiting a very long time. There was an inquiry, I think it was an internal one, to be fair, into that. When is that reporting back, or has it reported back to you?
I might ask Dr. Bloomfield to comment on that one. I think there's some matters of record here, that have already been well canvassed in terms of what we were told and so on. So I might ask Dr. Bloomfield to.
Yeah, thanks, Minister. Yes, I commissioned actually an external review, and I've received that just recently. We're working through the recommendations, and I intend to release that in early June and make myself available also to the media to respond to questions about that.
Okay, so you've got it now.
I have, yes.
Have you seen it, Minister?
No.
Okay. Are you just intending to stay essentially hands off on that and let that be done with?
I'm sure the Ministry of Health will provide an analysis of that and make sure that we get to see the outcome of that investigation. And I'll look forward to seeing it too. Yeah.
Dr. Bloomfield, are you willing to share any findings of the review now, given you've got it and seen it? Why do we have to wait till early June before we get made up?
Well, just to reiterate what the Minister said, in fact, I've certainly publicly talked about the problems that we had, apologised to the people who had to wait, as you pointed out. And the purpose of the review is to look at what if any, underlying causes, or what was the root cause of that issue that arose, and what we can learn from it, and what changes we might need to make to the system to make sure that doesn't happen again. So we'll have a look through the recommendations we've got and be able to respond to those, and then make the report available with the response, and I'll make myself available to answer any questions.
Okay. Mandates, more generally, obviously they've been removed for the vast bulk of the workforce who were affected by them, but there's still healthcare, corrections, etc. You've got a timeline in mind for the phasing out of the remaining mandates?
We keep them up. We keep them under regular review. So what you'll see is that those mandates are constantly shrinking. So the number of people covered by the mandates is constantly being reviewed, and it has already shrunk several times. And I think that that's the way it's likely to go. So I wouldn't say that there's a specific time frame for everybody, but I think that the number of people covered by them is likely to continue to reduce over time.
Okay. I think David might have touched on this issue, but I've had a number of people contact me who are required to get boosted because of the healthcare worker mandate, but they've had COVID, and therefore they can't get boosted because the GP won't tell them that, or the system doesn't allow them to get boosted, basically. You know the issue.
Yeah.
Is that being fixed?
Yes. So they get an extension, basically, so that they don't have to, because they can't comply. So
yeah, exactly. Why did it take so long to fix that? Because it's been around for a while.
I don't think it necessarily did, but I think there was certainly a communications challenge around it. Yeah.
Right. Okay. Right.
One more, Chris.
Okay, one more then. Contact tracing, obviously, scanning stopped on the 23rd of March, I think. Well, it was announced on the 23rd, stopped on the 25th. So it feels like months ago. It was actually only
It's not that long ago, I know.
No, it's only 6 weeks ago. It's been a long year already. When did you said before, I think contact tracing still happens on the margins. What do you mean by that? What does that mean?
I don't know if we've got anyone here who can speak to that in more detail, but
It's quite a holistic process.
actually, Dr. Bloomfield probably wanted.
Thanks, Minister. On the margins, well, the margins are where it's a high risk setting, for example, aged residential care, then that's when the team kicks into gear. But most of the team that was doing the contact tracing is now actually involved in our case investigation and follow up, the phoning up of people who register a rapid antigen test to see what support, if any, they need. So we've got that capability and capacity still in the system, but it's mostly not being used for contact tracing. It's just those high risk settings now.
Thank you. Dr. Elizabeth Kirikiri, then David Seymour.
Kia ora, Minister, and kia ora, Dr. Bloomfield. I can say I want to add my acknowledgements of all your work and the fact you're leaving. Since you've become a gay icon, I can confirm that rainbow communities everywhere are devastated, and wish you all the very, very best. My questions, though, are specific to ventilation.
Oh, yes, sure.
And, of course, my notes just disappeared. So the first in schools, and I'm conscious of the open letter that was sent by 150 plus doctors for what they're calling a vaccine plus strategy, but improving air quality in schools, inside classrooms, so parents feel safer having their kids in school. I think most of our parents want our kids back in school. I hope that that's not far away, but where is the thinking up to with that?
Yeah, so look, I think that it is important that we look at the evidence around what works and what's effective here. So a classroom with a window open by an inch or two is going to have better air ventilation than this room, which has quite sophisticated artificial ventilation. Artificial ventilation is what you use when you can't have doors and windows that open, but actually having doors and windows that open is by far and away the best way of replenishing the air in a room. The portable air cleaners, which we've purchased, and we have enough of them, we've got about 5,000 of them, so enough of them to use them in spaces where natural ventilation is either impossible or will become more difficult. So I'm talking about, schools that get covered in snow, for example. You have to have some alternatives there. Other schools will be in a position where they can increase their natural ventilation in winter, but need some financial support for that because they'll have to spend more money heating their classrooms. And so we're working through that with those schools to make sure that can happen. But the replacement rate from having the doors and windows open is, you're looking at more in the vicinity of 15 air changes per hour in the room, whereas a portable air cleaner, you might get, maybe 3 air changes per hour from a portable air cleaner. So it's still going to, even with the windows open a small amount, you're still getting a greater rate of airflow than through a portable air cleaner. And those aren't numbers we've just come up with. Ministry of Education worked with NIWA to actually get some, good scientific measurement around that, specific to a classroom context. So by far and away, the natural ventilation is still going to be the best option for most school environments. In terms of how we monitor air quality, every school in the country has been given at least one CO2 monitor, and there are more of them available as well. So where schools have a finding that they're having issues, we could flood the school with CO2 monitors if we need to put one in every room if there was a particular concern about that school. So we've got the capability to be able to do that. So I do think, it's a natural human instinct to think, we need to have a machine to do everything, when actually there's a natural solution here.
Oh, I am very much a fresh air advocate in that sense. And just following on from that, is there any, given not every space can have a monitor, not every space we can open windows and doors, is there a plan to look at the building code? And when we're creating new buildings, when we're looking at universal design?
Yeah, and look, I mean, this is again just a terrible generalisation, but I think it would be fair to say New Zealand, going back a long time, used to build schools really well. We built them towards the sun, we built them with good natural ventilation and so on, and then we had a period where we built them really badly. Hutt Valley High School, which Chris Bishop will be familiar with, was a good example of this. They built a building right in the middle of the school that blocked out the light to all of the other buildings. And it's now been demolished, and the air quality and the sunlight and everything in all the other buildings is massively improved. So I think we build schools better now than we did for a period. Another thing that I would say about that is we've built schools in New Zealand, we've been at our best in school construction when we've built to standardised designs, where schools have designed their own. That's where they've tended to have poor ventilation, they've been leaky, they've had all those issues.
Because not architects, not designers,
that's
not
right.
engineers.
So moving back to standardised designs, which is, if you go around the country, you'll see the standardised designs of the 50s, 60s and 70s, and they still serve us really well. Going back to that actually gives us much better value for money and better quality learning environments.
Thank you.
David Seymour, then Dr. McCallum.
Yeah, thanks. I just wanted to go back to that discussion on pre-departure testing and hospitalisation. I think your words were that the level of hospitalisation is minimal, or the difference made by pre-departure testing to hospitalisation is minimal. I don't know if you've got a lot of advisors here. Is there anything more specific on that?
I might ask whether any of the health team want to make a more detailed comment on that, but as I've indicated, I mean, I think pre-departure testing's days are numbered. Dr. Bloomfield?
Oh, thanks, Minister. Look, just one comment. One of the challenges with pre-departure testing right through the pandemic, even when we know it was playing a really useful role as part of keeping the virus out of the country, is it's never been possible to determine how many people didn't travel because of a positive pre-departure test. So it's hard to then make a judgment about the flow-on number of cases and or hospitalizations that might be presented while we're in Omicron. But just to reiterate the comment the Minister's made, certainly our advice is that pre-departure testing doesn't have the same role that it's had in the past.
But yet people are still required to do it. Could I just ask about a comment you made, Minister, in an interview with Newsroom published this morning? You said that kids pick up public discourse as happening around them, and I think there's quite a lot of anxiety and catastrophizing going on around COVID-19, and I think kids pick up on that. I just was really fascinated by that statement. Who is doing the catastrophizing, and who is experiencing the anxiety?
I can't remember the exact part of the interview that I made that comment in, but yes, kids do pick up on what's happening around them, but the catastrophizing is at different levels. So you get that from all ends. So on the one hand, in some communities, the things that kids will be picking up on are that anti-vaccination messages and things that will be making them anxious about that. On the other hand, there'll be people picking up messages around mask use and ventilation, for example. Ventilation's not good enough, every child should wear a mask, etc. And so yeah, there is, kids have certainly picked up on that.
Do you think the Prime Minister using words like killer virus, tricky virus, tens of thousands of people may die, would have contributed to that anxiety and catastrophizing?
We're at a very different stage of our response to, we wouldn't have heard anyone in government using those words, those phrases recently, but certainly earlier on in the pandemic, they were absolutely factual descriptions of COVID-19.
Still true, I guess. I just wonder about visa waiver countries. Now, I saw, and this is not your fault, but One News opened with "We're open to the world," and yet 14% of New Zealanders originate from visa waiver countries. We're thinking about Kiwis of Indian, Sri Lankan, Chinese origin. Their non-resident family can't come back. And I know you're not responsible for immigration, but is it a question of immigration, or is there a public health reason why we haven't opened up in the absolute sense like we were pre-COVID?
No, I mean, I think as I indicated back in February, there were two factors at play back in January, February. One was public health and the other was immigration. And the further down the road we've got with this, the lesser the public health factor has become, certainly for differentiating between countries, and the greater the immigration constraint is. So this is really about making sure that we are sequencing the pressure on the immigration system in a way that means that the people who we want to be the priority are actually able to get the priority that we need them to get.
So someone coming from India is not a greater public health risk, it's just the visa processing hasn't caught
That's
up,
correct.
basically.
So just a quick sup on that. I feel free to direct me to Chris Farford, but a lot of people wonder, you know, why is the immigration system not better than it was 2 years ago when there's 500 more staff working at immigration?
Well, and they've just had 2 years off.
To be fair, the immigration system was under a lot of pressure before COVID-19.
Yes,
and there was some reorganisation in the period just before we became the government that perhaps didn't necessarily deliver. I don't want to make it a political thing because I don't think it was a political decision, but there was some reorganisation of the way some processing was happening and so on that I'm not sure was delivering.
Well, you guys campaigned there was too much immigration.
What was necessarily required. But bear in mind that we have had a lot of people who are currently resident in New Zealand that we've given the opportunity to apply for residency, and that those applications are still working their way through the system, and they do require quite a lot of resourcing to process them.
Finally, David, you've got one more question.
Finally, there's been some recent reporting on social media listening reports from the New York-based Analect prepared for the DPMC. Every 4 days, around $2,000 of reporting on what people are saying about COVID on social media. Were you, as COVID-19 response minister, privy to those reports, either occasionally, always, or some of the time?
No, and I actually asked my office just before I came down here just to check that, and I think they were able to find an example of a report where they were mentioned, but not like I certainly was not getting the reports. I was not getting regular updates on the reports. They were largely being used to inform the advertising spending, so they were being used, you know, by the people who were doing that.
How did you become aware of that fact?
What's that?
That the purpose of the reports was largely to inform the ad spend.
Well, the ad spend and the communications. So, you know, the messages that were going out.
Really, a $2,000 report every 4 days to target advertising.
Well, you'll find actually that many of those who are doing significant advertising campaigns spend a lot of money on that.
Oh, wow.
That's how you actually get the messages in front of the people who you need to get them in front of. This is, yeah, I know there's this great thing that somehow the government's doing something that businesses aren't doing every single day. I can tell you they are.
Well, no question about that. It's just what else are they using it for?
Right,
And
thank
it does
you.
seem a bit
Very quick
excessive.
stuff from Dr. Retty and then
It
Dr.
was originally
McCallum.
his thing.
Thank you. Can I just supplement that? Why have all the reports not been released under OIA? If there's nothing to see here, this is just routinely associated with.
Well, they are being released under the OIA. In fact, when my office looked to see when have I seen them, in fact, and the best examples they could find of me having seen them was in processing OIA request responses. So I can tell you that if they haven't been released, they're on their way through the system.
Okay, so various media reporting that they've been declined because of the time and resource required to aggregate or whatever. Regardless, the quantum of reports are out in public domain. It would be reassuring.
Well, look, they're not my reports, so I don't make the decisions about the release of them. Yeah.
Thank you. Final question from Dr. Tracy McCallum.
Thank you, Chair, and thank you, Minister and Dr. Bloomfield and everybody for your time. I'm just thinking about the epidemic notice per se that's been in place since 2020. And which we acknowledge is unlikely to remain, you know, as necessary in the long term. And you've touched on a couple of things that therefore will change in terms of our regulatory sort of systems. But is there anything else or anything other, any other points of sort of clarity that you can talk us through those that will mean necessary regulatory changes from now on?
I think one of the things we have to recognise about the COVID-19 response is, you know, starting back from when the COVID-19 Public Health Response Act was passed in 2020, we ended up with a system where you had regulations layered upon each other, different orders kind of one built on the other and so on. And the process that we've been in has been disaggregating that, because it's not necessarily, you don't necessarily work backwards sequentially in the order that you moved forward. Sometimes you want to delve deeper and remove something that might have been earlier on and leave something in place that might have been later on. And that's not always an easy process. The bit that I think we have to, which I have made very clear, I think we have to work towards a New Zealand without the Covid-19 Public Health Response Act. It was only ever intended to be a temporary piece of legislation. And at the moment, there's still the unknown, and there's still the potential that we'll have to respond quickly to something. So at the moment, the Act leaves in place a framework that allows us to do that. But in terms of our regularised response, I want to see that transitioning out of orders under the Covid-19 Public Health Response Act and into, if there are elements of it that might need to be enduring, then we should transition those into a more normal government decision-making framework with all of the regular scrutiny that applies to that, and away from the kind of the emergency response framework, which is the Act. So I think there are two issues at play. How long will the Act be there? Well, it'll be there as long as it needs to be there, but many of the things that we rely on it for at the moment might not be.
Thank you. That concludes the committee's briefing into the government's response to COVID-19. Thank you, Minister, and to the staff as well. Dr. Bloomfield, much has been said in terms of congratulating you and thanking you. On behalf of the Health Committee, can I acknowledge the work that you've done in your role as Director General over what has been an extraordinary period, and join with colleagues in wishing you well for what comes next. And on that note, we will move to what comes next for the committee, which is turning our minds to the continuation of the COVID-19 Public Health Response Act, which has been referred to us. Minister, do you wish to make any comments?
Well, I think I just alluded to it in the answer to the last question. I've been pretty open about the fact that as a parliamentarian, if we take the fact that I'm currently a member of the government and currently the minister responsible for that act, if I just go back to just being a parliamentarian, the COVID-19 Public Health Response Act has always made me feel relatively uncomfortable. And I think any member of parliament that says that they are comfortable with it probably should actually rethink that, because I think those kind of extraordinary powers should only be used in an emergency situation, and only for as long as they are absolutely justified. So every single order that I have signed under that act, I have applied that filter to. I basically said, is this absolutely required? Or is this something that should follow a more regular decision-making path? Vaccination is actually a good example. We're dealing with an issue of that right now, where could we use some of the emergency provisions we have either under that act or under the Epidemic Preparedness Act to make the changes required for fourth doses of vaccination? It's arguable, but I think it would be stretching the intention of that when more regular decision-making processes could be used to achieve the same outcome. So my view there is that those mechanisms should only be used where there's no other alternative, and where a more regular decision-making alternative is available. That's what we should be striving for. The orders made under the Act have been, progressively dismantled, as I've indicated. And as I said, it's not just a case of you don't just withdraw them in the order in which you put them in place. They layer upon each other, and so going back and disaggregating them and working out which bits do we need to keep for a while and which bits can we remove now isn't a straightforward process. So we've been working our way through all of that. We will reach the point, and I hope it will be this year, where I think the vast bulk of our COVID-19 response can transition to a more business as usual approach, where if there's a need for any existing, ongoing protection measures, that they can be handled in a more regular way rather than under that Act. Whether that Act continues to remain, something that the Parliament will no doubt turn its mind to, and the government will have to make a recommendation to the Parliament about that. But I certainly think that as soon as we're in a position where we're confident that we won't need those provisions, we should remove them.
Thank you. Questions, Chris Bishop?
Yeah, look, this is not particularly political. I think everyone's keen to get this right. So I'm just looking at the order paper now. There's a motion which was lodged a couple of weeks ago to extend the Act to end of the year.
Yeah.
So it's fair to say that's just a if we have, because I think it's early June it comes up for.
Yeah,
Has to be
that's right.
So just kick it out to the end of the year and then sort it in the meantime. Is that
Yeah.
decision?
Yeah, because as I indicated, there's still some stuff that's being disaggregated through all of that.
Yeah.
So, you know, what will be the enduring settings at the maritime border, at the air border? You know, those are things that we have to look at. You know, a good example is, I'm not saying that, it's kind of an example and it's kind of not. But if you think about post-September 11, for example, there was a whole lot of immediate response. And then over the course of the next year, it transitioned to a new normal.
Yeah.
And I think that that's where we're at with COVID-19, potentially. If we don't see new variants that change the game and everything, we're transitioning to a new normal.
So so obviously to replace the Act, work out what the new Act looks like, is a lot of work. Have you started the work?
Yeah, but it might not be a new Act that's specific to COVID-19, for example. It might be insertion into our existing legislative frameworks. So there's existing law around the maritime border and around the air border, and it might be that if we think that there's anything enduring required there, that we just slot it into the regular machinery of government legislation and then remove that.
And the Health Act needs a...
Well, the Health Act, I tell you, if I was a minister, if I'd stayed Minister of Health for longer, the legislation in health needs some work.
Yes, it does. So I guess the question is, so yeah, I mean, you very quickly, I can see where this is going to go. You very quickly go, oh, you'll replace the Act or repeal parts of it. And then it's like, well, what do we do about this? What do we do about that?
Yeah.
It gets bigger than Ben-Hur, potentially. You know, has the work started on the scoping exercise?
Oh, yeah, no, totally. And in fact, you'll see that many of those things are already transitioning. So if you look at the volume of our COVID response that's reliant on orders made under the COVID-19 Public Health Response Act now, compared to what it was 2 months ago.
Yeah.
A lot less of it's reliant on those orders now than it was even 2 months ago.
Yeah.
And that just continues. And so it's almost like by process of elimination, you know, you kind of go through and scrub things out and then you look at what's left.
Yeah.
And you say, okay, well, where should they naturally sit?
So who's leading that work? Is it DPMC doing a cross-agency thing?
Combination of
You've got
DPMC,
customs or, you know.
combination of DPMC, Ministry of Health, and the Border Executive Board, so which is led by Customs.
Look, I mean, it might be a bit out of school, but are you amenable to us potentially having those officials come in to give us a bit of an update?
Yeah,
it'd be quite good to get a sense of that.
Yeah, no real issue with that. And I mean, just in terms of the Act itself, you know, I originally had this idea, a bit naive, I guess, when we first passed the Act, and then we passed a series of amendments to it. But the idea was that we would get an Act that was in perfect condition, which could then be repealed and just sit on the shelf.
Right.
So that at some point, if there was a future pandemic, they could just dust it off and put it through the house again.
Right.
The reality is that's not the way that Act, as you know, has worked. The Act now looks vastly different to the way that it looked when we first passed it. And the idea that you could have this perfect piece of contingency legislation sitting on a shelf somewhere, I've kind of come to the reality that that's not what's going to happen.
Right. So, but you also don't want it sitting there in abeyance, you know, with big powers for ministers to just kind of.
No, I think we get to the point where the Act has no legal standing. It might sit somewhere in someone's drawer, but it would have to go back through Parliament in the event that a government needed to use it again.
Okay. All right.
Any more questions?
No.
Any other questions for the Minister?
But basically, the work's it's cutting a lot, TLDR version. It's going to be a big job. There's a lot of work underway, but we're going to kick it out until the end of the year for now.
Well, I mean, it's already well underway. And like I said, there's a lot less hanging off that Act now than there was a couple of months ago.
Well, can I ask one question?
Yes, David Seymour.
I just wonder about, and this is, you said that these sessions could maybe blend into each other. I just wonder about the restrictions on doctors issuing exemptions. And I just
very liberal interpretation.
Yeah, and I just give you a thought experiment. I think if the Justice Department said to the Law Society, sorry lawyers, there's some advice that you just can't give. I think that give a response that is linked by abbreviation to the term gluten-free. Now, that's what doctors have effectively had. They've been told that they just can't give exemptions for the patient in front of them. And I wonder if that was the right way to go about it. I can understand that you're going to get some crazy doctors who think the vaccine's terrible and it's some sort of humanitarian mission to give out hundreds. But you could easily detect that behaviour. Whereas, I've come to know a number of people who, are very rational, and their doctors would like to give them an exemption, and their doctors have been blocked by the Ministry of Health. And I wonder if that will come to be regarded as quite a strange concession for a profession like medicine to make. Law wouldn't make it. And I wonder if that's something that you'll consider differently when it comes to, I guess, respecting professional integrity, because I think the medical profession have in many areas been quite run down. Another area is the lack of inclusion of GPs at the beginning of the vaccine rollout.
Well, that was, that was just a practical consideration. The bigger vaccination centres had the potential to get through a greater number of people faster. But, adding GPs into the program progressively significantly upped the capacity. But at the beginning, we just wanted the fastest volume possible.
Sure, but then it's the long tail that became the issue.
Understood. But look, on that issue around GP exemptions, I think it's probably time to have a look at that again.
All right. Thank you, Minister. That concludes your time with us this morning. Thank you to officials as well. The committee will now move into a private session.